Right. Those who just came in, I'm Hamood, one of PDY3s, and welcome. We're going to start a bootcamp series, and the purpose is to fast track your learning, the things that you need to know, the basic things, common things that you're going to see in the floor. We're going to start with sepsis, and it's not a coincidence. It's probably going to be the number one thing. Every time you get an admission from ER, you got to think about, okay, do they have sepsis or not? Did they do this thing for this patient or not? Let's just start. I would like to open with Sir Osler. He said, medicine is a science of uncertainty and an art of probabilities. And you're going to see sepsis is the number one example of uncertainty and the art of probability. You would never be certain by the time you would be putting orders. You would go based on the data you have, and then you confirm. So this is what we're going to talk today. We would have a case like a real life, what are you gonna get? We're gonna lock down some definition, up to date, new guidelines, previous guidelines. We're gonna talk about real life management, how it is different from the book. We're gonna talk about epic navigation. It's a simple case, 58-year-old male. He is presented with left leg redness for 3 days. Yeah, present for 3 days after a scratch. Subjectively, he was having some chill. You can see in the pictures. Before I show you the vitals, what do you think is attacking?
Vitals.
This is his vitals. He had a fever of 100.9. He tachycardic. His respiratory rate is fine. His blood pressure is okay. He's breathing fine. His white cell count is 15. How many of you think, just raise your hands, that this is sepsis? And hold your thoughts because it's going to depend on what definition are we going to use. So what is sepsis? It's your own body's response against the bacteria. This is a by the book definition life-threatening condition from dysregulation of the immune response to an infection. It's not always the bacteria killing you. It's your own immune system, your own coagulation cascade pathways. You don't need to remember this whole table. This is just a background. Sepsis has been there as we have the modern medicine. It used to be SIRS. You guys might have heard about systemic inflammatory response syndrome. And if you have hospital infection, call it sepsis. And that was the case until 2016. And then the new guidelines came in and they said you can have sepsis if you have an organ damage. Did that translate to the practical things? No. But we're going to talk about it. So it used to be previously sepsis, severe sepsis if you have an organ damage, and septic shock. In 2016, they retired the term severe sepsis, and it's only sepsis and septic shock. They say you can calculate a score in 2016 to say if someone has sepsis. You don't need to memorize it. It may in next 2 years, if it comes into practice. It's a SOFA score called Sequential Organ Failure Assessment. 6 organ system, every organ system gets point from 0 to 4. And if someone has 2 points or more than 2 points increase from the baseline, and they have an infection, that's sepsis. Why do we use it? And is it important to know? Yes, there's a clear association of mortality with the SOFA. It's not just a, it's clear. With the SOFA score 10, 15, your mortality is going to 100%. Now what the term that we see in our real life, some people would say, oh, did you see the Q-SOFA? What is Q-SOFA? It's a quick SOFA score. It was designed to predict the mortality, not to screen the sepsis. And that has been the case to this day. You just have 3 systems, you give 1 or 2 numbers. If it is high, the mortality is going to be high. This is the thing we need to know. Third, we have 4 things. Temperature, it's not always a fever within 30, hypothermia, less than 36. Heart rate, usually tachycardia heart rate is more than
120.
Heart rate, right? But in here, heart rate more than 90. That's the difference. Keep an eye on that. Tachypnea is your breathing is more than 20 times and your white cell count more than 1,000 or less than 4,000, or maybe you have more than 10% of band cells. This is the old school. This is to this day, we're going to keep doing it as long as they make the changes. Why are we doing this? Why are we lagging behind the time? Since 2016, we have new guidelines because a lot of hospital billing diagnosis is dictated by the CMS. What is CMS? It's the Centers for Medicare or Medicaid Services. It's like a federal insurance that pays for the patients, most of them. And all of the private insurances, they follow whatever rules, standards, reimbursement CMS says. The CMS has the diagnosis sepsis, severe sepsis, septic shock. Then your patient criteria 2 out of the 4, and they have a possible infection or a confirmed infection. It's sepsis. They have an organ damage, severe sepsis. If you're going to document as and date. If they have hypertension, you give them fluids, all those things. Their blood pressure is 80/50. Their MAP is less than 65. It's a shock. You need to escalate. You cannot keep that patient on the floor. They need to go to ICU. And then comes the multi-organ thing. If you can, you don't need to know the numbers. You just need to know the organ involvement. Better than their baseline, the organ dysfunction associated with infections, severe sepsis, documented. This is important to know. They say, the new guidelines say in 2001, it used to be 20 ml per kilograms. They changed it to 30 ml per kilograms of body weight. That's fluid if your patient is hypotensive, if they have lactic acidosis, that you need to give patients. But what if they are still hypotensive after that, or they still have lactic acidosis? That's the shock. That's what we call refractory hypotension to your fluid instrumentation. This is where you're going to call ICU. They need to be started on pressors, norepinephrine, dobutamine, whatever type of shock. This is good to know. Surviving sepsis campaign, whenever I said the other table I showed you, it came from this. This is a collaboration between our Society of Critical Care Medicine and the European Society. Founded in 2002, you can say it's a worldwide sepsis committee who looks up the data, who defines the new terms, and the hospitals, all of these things. Why did they do it? They're trying to reduce the sepsis, the mortality, the education, all those things. This is just, I made it up. You don't need to know, but you just can see the numbers starting from 2004. There was a time period you can do all those interventions in sepsis patient in 24 hours, up to 24 hours. In 2013, we say 3 hours. 2008, 1 hour. This tells you that every time they look at the data, they learn one thing: we need to act fast. We need to act fast. We cannot delay. We cannot afford delaying of. And if you go back, they say bundles. That's what that I was so confused. My whole intern here, like, frequently antibiotics. I called infectious disease doctor. What is bundle? So bundle is set number of intervention, labs, treatments that you need to put in for every sepsis patient. It is in the form of a sepsis order set in the Epic, and hospital tracks it in that way. I'll show it to you later. Why are these bundles are so important? What is the evidence behind it? This is a Korean study taken from their ICUs over a decade. If you look at the data, starting from 2008, the compliance of all those bundles and order set was like 25%. It went up in a decade, and mortality came from 50 to close to 30%. So it's not just hear and say. It's something that is proven. Now we're talking about bundles. As I said, in 2018, we merged all those 3 years and 6 years into 1 year. Those are the things that you absolutely need to do if you're suspecting a patient with sepsis. You need to check the lactic acid. You need to check the blood cultures, give them antibiotics. IV fluids or vasopressors depends. Always get the blood culture before antibiotics. Why?
Antibiotics affect or can affect the results of the.
Absolutely, they would affect, you would have falsely negative. You may never know what was the organism behind the sepsis, if possible. And this is the flow diagram of what is in our bundle. What is time zero? Time zero is by the time patient meets that SIRS criteria. Our time starts when we get the patient from ER. You put in the admit orders, it's 10:40, met the SIRS criteria, you have 1 hour to complete the bundle. And we always take a look, see if ER did everything or not. If we have to do. Time zero, you get the lactate, you get the culture, give them antibiotics. You give them fluids. Previously, we used to flood everyone in 30 ml per kg. And then we came with ideal body weights, and now it's more of a reassessment and then 30 ml if they need it. Take a look. If someone in the ER, they gave them 2 liters. Are you going to give them 30 ml? No. They have a heart failure. Their EF is 10%. No, we're not going to give them. We're going to individualize the fluid resuscitation to every patient. And we have vitals to look for it. We have lactic acid to look for it, like how much fluid are we. And then vasopressor. Why I'm talking about lactic acid, it tells what's going on at the molecular level. If it is going up, your body is shifting your metabolism from aerobic to anaerobic. It tells the tissue perfusion. If you look at the Zyte study done in 2007, when the lactic acid numbers go above 4, mortality reaches 50%. You cannot miss it. And it's not something you get it one time. If you get it, if it is high, you trend it. And the other study from the Jensen, it's from 2010, it tells that when you have a goal of 20% lactic clearance every 2 hours, you have mortality benefits.
How often do we trend the lactate?
Usually we get the lactic and then we give them IV fluids bolus, like a liter bolus or 30 ml per se. You try to give them in an hour, and then you after the. But it's a response from what intervention you don't want to get it again and again by not doing it. This is one of the largest study in 156 ICUs across the Europe, US, and South America. 28,000 patients. It tells us one thing: antibiotics, by the time they were given and the patient died in the hospital, it's an exponential rise by the hour. We cannot afford it. And the last line, those are the things we learn when we'll be on the floors together. Just remember, they're meeting the SIRS criteria. You got the lactic, you got the cultures. Don't wait for the attending to tell you you have your seniors. You got a patient in the morning, don't wait for the round to give them antibiotics. Talk to your team, give them antibiotics. And this is just the flow diagram from whatever we have discussed for now. Someone met the SIRS criteria, or you knew it, they have sepsis, and sometime EPIC gives you a warning. It's called best practice advisories. Sepsis has a system in it. I'm going to show you in a minute. Every time a patient has an active infection diagnosis and they meet 2 SIRS criteria, EPIC gives you a hard stop to deal with sepsis, or if it is a sepsis or not. So in any scenario, you think it is sepsis, your time starts. You get what things are we getting? Lactate,
Cultures,
blood cultures,
antibiotics.
and
Fluid.
fluid. The important thing again, reassess. If their map is not improving, what is map? Good question. And why are we keeping the number 65? Yeah, an organ perfusion, especially to the brain. Previously, this number used to be 75, 85, but the trials showed that there is no added benefit to have the high map and there are more risks involved. The numbers may go down to 60 in upcoming years, but for now it is 65. And again, if their map is low, their lactic acid is high, it's time to call the ICU. And most of the time, their first thing that they put someone on is norepinephrine. These are the things needs to be done in an hour. And after that, you can look up what is their source, try to hunt. You're gonna call ID for something, that's up to you. Then comes the order set. So just like, I don't know if you guys know, there's an admission order set. When we admit someone, we put in the admission order. It has certain labs in it. But hospital cannot track it if you don't put in a sepsis order set. If someone is admitted with sepsis, then they cannot track it. And since it's something that CMS tracks it, lagging behind the quality, reimbursement, money is tied to everything. So we're gonna see how does it look like and what are we gonna do when the best practice advisory or a hard stop is gonna pop up. It is already in the hospital. It's an infection. They were not meeting the search criteria, and the next day you came up, opened the chart, so they're gonna stop you. Deal with it. They have some vitals up there. If you know this patient had sepsis, you can click on open order set, and it would open up the order set for you. But if it is, there are certain things that you can do it if you're already treating and you have placed the order set 2 days ago, you don't need to do it again. Or if it is not sepsis, because this system is triggered by SIRS. It's very sensitive, but it's not specific. So you can put in that it's not sepsis, the SIRS is from other things. What other things can make you have SIRS?
Pain.
Pain? Anyone?
Surgery. Post-op.
Pain, PE, trauma, like someone just had asthma. So,
Running up 3 flights of stairs very fast.
oh my God. Yeah.
Who is doing that nowadays?
That was it. All right. But if you don't know, if you're not sure, you can always click on that. I need to review this patient. Click here, you have 5 minutes to review, but again, don't delay the kid. Go to the open order set. And if you don't get this trigger alarm and you want to put it in set for your orders, you can freely type in here sepsis. Sometimes you may see it would say your ED sepsis, let's open that up. For this one, this still says compliant. Remember, you don't need a confirmed sepsis diagnosis. Suspected or confirmed. You open up the order set. This is how it looks like. I don't know how clear is it, but I can read through it. The first thing is asking for you blood cultures, lactic acid, empiric antibiotics. And if you look at the fluid boluses, there are 2 fluid. First one here is 30 ml if you think your patient needs it. And the other one in exclusion, like if they got a bolus in the ER, they don't need it, or they got two liters, they need 1 more. So you can use the other one. You can check on the vital signs the nurse would have to do, hemodynamic monitoring, oxygen if they need it, input and output, and then, as I said, then you go behind the source, you try to find it, you can use all these things. And you can use all this imaging, you can check your CAT scan, you can do cardiac studies, some stat labs, whatever source you're suspecting. You can get ESR, CRPs in here, and you see the steroids, that's mainly the ICU thing. When they are not responding in the shock state, we don't do that on the floors for sepsis. And then you have to add that in your problem. Before last year, we used to free type all of our problems in the chart. It was easy, but it was not a good thing to do. This time we're adding problem list by the time patient comes in, and then it goes onto your chart by itself and all the plan So you just add sepsis one time, it's gonna pop up on every progress note you're gonna do. So how you're gonna do, you're gonna click on the problem list, add sepsis. Click accept. What's POA?
Was on mission.
Present on admission, not power of attorney. You need to know if the sepsis was present on admission or not. This is how your sepsis diagnosis. Again, it changes if they got sepsis in the hospital, if it was present on admission. Money's tied to it. So is the quality metrics.
And
Can I-
just to mention, even if you're only suspecting that
Yeah.
it was present on admission, go for yes.
Yes.
Okay, you don't need to have the real evidence. If you think most likely it was, yes.
Yeah.
Can I say something?
Yeah.
So POA, what else could it mean? Power of attorney, sure. Present on arrival. So it's hard to know what that time zero is. Anybody in here going into emergency medicine? Exactly. So we are not the arrival provider. We're the admitting provider. So when you say POA, coding doesn't know what you mean. The benefit is Epic will always put present on admission when you attach it to present on admission. But if you say POA, they go to the first timestamp on arrival. So if you're saying that something is present on arrival, you're digging the emergency room provider a hole that they might not be able to get out of by saying that. We're the admitting providers. If it's present when you admit them, that's great. Say that, but don't just put POA.
Again, and our time starts when we put in that admission orders, so that's why present on admission, not when they came to the ER. These are some of the things that our hospital tracks, like we need to have water set usage more than 80%. And compliance with that bundle 70%, not to scare you, but do the right thing, you can meet all of these things. You need to order antibiotics from time zero when you got the patient or when they first met source criteria within 30 minutes. And the nursing staff have to give it within 30 minutes. This was the talk for today. Any questions?
I have a question. When we're admitting a patient with sepsis, we use not only the admission order set, but we also add to the order set the sepsis. So we use both order sets.
Yeah.
Repeat.
So he asked a question about using the admission order set that we're gonna use for every patient that you're admitting. Do we need to use another order set for sepsis? Yes. Again, you could have done everything, all the orders, lactic, blood cultures, antibiotic. Hospital cannot track it, that if you did the sepsis bundle or it's the only way to track it is
Use the sepsis order.
order set. Do you have anything to add?
Oh, yeah. But take your question.
Who goes there?
So if, like, timing is so important. So if you like get an admission, you're kind of like pretty like charting
Right.
before you go down and you're like really suspecting sepsis, you just go ahead and order set before you even like lay eyes on the patient based on like chart review and stuff.
Usually the ER tells you like, why are they calling you for the admission? They're like, hey, I'm suspecting pneumonia. The X-ray looks or the CAT scan rates on it. First thing you're gonna look at the vitals, ideally. If you're sitting in the camera, it's a 2-minute walk.
Mhm.
But again, search criteria, expected. Confirm. You're suspecting, when you're suspecting, put in the order set.
Is better to be aggressive early
Yeah.
than to have to play catch up for a septic patient.
No, we could just cancel it. It's not, we could just cancel it.
Okay.
What's a dose of Rocephin versus somebody dying of septic shock?
Yeah.
I mean, yeah, one dose of something isn't going to cause, multi-drug resistant organisms. Like prolonged antibiotics when you don't need them will cause multi-drug resistant organisms. So just being mindful of if you suspect it, you suspect it. And then when you confirm that it is not there, you stop treating them for the thing that's not there.
Just keep in mind, you want to have blood cultures drawn before the antibiotic. If that is possible with a time frame.
Right.
Absolutely, you wait for a couple of minutes. I'm talking about minutes, not half an hour, minutes. If that is not possible, then you give the antibiotics, but you're documenting antibiotics were given so many minutes before the blood cultures. Because once the antibiotics are in and the blood cultures is being drawn, then the likelihood that it comes out positive or correctly positive, is very reduced.
And that is something that, like, sepsis is a big deal, right? Like, people die from your body infection and your body's overreaction to said infection. So, nurses are also, and we meet once a month in sepsis committee and discuss with nurses, the fallouts that we have. So if you go back the one, yeah. So you can see there to the 30-minute time zero to antibiotic order and then administer. Well, that is also in conjunction with acquiring blood cultures prior to administering those antibiotics. So you basically have 1 hour, the nurses and us have 1 hour to order and administer antibiotics and obtain blood cultures, lactic acid beforehand. So
Any more questions?
May I ask, please?
Yeah.
So in what cases we order urine culture?
So the question is when we can order the urine culture. So here,
Along with blood.
again, these things, and then you go for the source. And then I showed you two additional tests that you can do for your sepsis patient. There are stat labs, so we don't send urine culture straight up. We're gonna send them for urine analysis with microscopy. If they have pyuria, bacteria in it, it's gonna reflect it to culture. That's how it is.
Just make sure the order you pick is the one with the reflex.
Yeah.
Because otherwise they don't send them for cultures and then we miss the opportunity. Once the antibiotics start, then it doesn't matter.
So why it's not automatically reflects?
Because if your urine analysis is negative, you don't need to send it for culture.
If you don't have a bacteria or pyuria or leukocyte esterase or nitrates, what are we gonna see in the cultures?
Yes, but I mean, when we order and then you order and then if it's positive, they would automatically reflect.
Yes, so there are two types of order, urine analysis with microscopy, and there's urine analysis with microscopy with reflex-to culture. Always use the second order that says urine analysis, microscopy, reflex.
I remember sometimes you're getting your analysis for renal issues or
Right.
electrolyte issues. So you might not be, you may not have symptoms associated with, so there's no reason to do reflex. Pricing thing, they're more expensive to attempt to reflex if you need to. Also, you don't want to end up with a positive urine culture for asymptomatic individuals. Now you have asymptomatic bacteria, and then it's gonna ask you, should you treat this or not?
Yeah, that's ask ID.
We would only use that if we're suspecting urinary tract source.
Yeah, and if you don't know, just forget it. But
I'm just asking because for those who take step 3, they like your teaching. If you meet certain criteria, you need to order blood culture and urine culture, and you can. I'm just
Are you-
from exam.
Are you talking about the
Then
cases they have in step?
Yeah.
That's a different thing.
I know. That's why I'm asking.
I remember that. Yeah, you gotta,
Yes, and you're absolutely correct. In the mixed-up question, the USMLE questions, they want to know that that is in principle necessary. Okay? The real world is then a bit different.
Yeah.
You don't want to order too many urine cultures because the definition of a UTI by Medicare is different than in the real world it is. And as soon as, for instance, a UTI is being diagnosed during hospitalization, the hospital doesn't get paid. The hospital is annoyed about every urine culture which comes in STEMI positive back, even if you're not treating it, okay? Because they get zero payment for it. So, but when we're talking about mixed up and USMLEs, yes, it is the so-called all-around culture.
Right.
They full set of culture.
I believe the reason behind they want you to think about is you look for the source.
Mhm.
It's part of the thing that can have the source. Okay, any questions? Hey, ready. Since we.
mind if I throw a couple things before we, or do you want to do questions first?
Yeah, at the end.
Okay, that's cool.
Since we
Still
just
want
learned
your
a few things, we're gonna talk about how we can translate the practical or boards. If anyone wants to read the question.
Hamood, I think we have a question. Give me a second.
Okay. Somebody raised their hand. Let's get a question from Wesley Chapel.
Hi, yes. So we had a question here at Wesley Chapel.
Somebody
In
raised
terms
their
of
hand.
sepsis, what is the appropriate criteria for discharge? Hi, can you hear me?
Maybe you can ask them yourself. One question they can unmute themselves. Anyone from Wesley Chapel, if they have a question, please unmute yourself.
I think the issue is that.
I don't wanna type
Because there's
that
the actually unmuted.
They can hear from.
No, we can turn that on mute, remember.
The speaker is off. But you can hear us. So we got a question asking, what is the appropriate criteria for discharging sepsis patients when they're no longer in sepsis? You follow a patient over 48 to 72 hours. That's enough time for all the cultures to come back. And for your confirmation that the sepsis or not having sepsis. And based on that, if it's UTI, it's complicated. Management is different. If it is multi-drug resistant, you may need to send them on an IV antibiotic. So it depends on what was the source of sepsis. It's individualized. But by day 2 or 3, you should start having answers. Why did that have sepsis?
But a couple of rules are very clear. A patient must be febrile for 24 hours anyway.
Right.
Okay? The blood culture, they were positive to be negative, right? The white blood cell.
Depends on the.
Depends
what type of culture?
Depends on.
I'm negative.
Yeah, correct. What else is there? If the white blood cell count is going up, you cannot discharge. You need to wait at least till the white blood cell count is stabilizing. So there are so many influencing factors that you literally cannot give one answer correctly.
Right.
Because at the end, it's then as well the clinical picture of the patient in the bed.
All right, let's go back to.
I have a question.
Yeah.
How often do teams here send patients to with home?
Yeah, the question is how often we send patients home with IV. Quite a lot. With positive blood cultures, gram-positive cocci, ID, infectious disease,
Okay.
case manager, they work with the insurance and we try to set up, we call home health care.
Mhm.
Someone comes in, they have IV antibiotics arranged at home before the patient leaves.
Yeah.
And we put in the PEC line or midline, depending on the number of days they need. And then certain labs that need to check, then ID coordinates with everyone.
So we would always have ID for those cases.
Depends, if you have a bacteremia, yes. Or you put in someone on empiric antibiotic, you could not find the source, but they got better. You wanna get some answers for the coverage by the time of discharge, you can have ID of both, yes.
But you're selecting a patient very, very carefully, which you are allowed to send home with an IV PEC line. Anybody where you have a suspicion of IV drug use is anyway a no, you know? Anybody who is not following up or will not let visiting nurse in is a no. You know, so before you think about that, make sure that the patient is fitting this kind of treatment.
We had a couple of patients who stayed there for a month.
Yeah.
Because they were IV drug user, they completed the
babysit.
coursing here.
Or social cases that don't have.
Yes, even social cases that resolved, but more of the IV drug user suspicious, or they're gonna go into harm.
And remember, you also have to ensure that repeat blood cultures are negative, except in the case of pan-sensitive, gram-negative or bacteremia, like an E. coli or something. You have to make sure that the repeat blood cultures are negative for 48 hours before you stick a PICC line in, otherwise the PICC line will get seeded, particularly with the gram-positives. But don't worry. It's like Pseudomonas even other ones.
But for now, bundle order set. You learn all these things during the year. Let's read this question again.
Questions?
I can read it. A 54-year-old man is evaluated for fever and altered mental status of 12 hours duration. He has diabetes mellitus and underwent a prostate biopsy 5 days ago. Temperature is 37.8 Celsius. Blood pressure is 80/15. Pulse rate is 118, and respiratory rate is 27 per minute. He is confused. Extremities are cool with polaris. Blood cultures are obtained. Serum lactate is measured, and empiric broad spectrum antibiotics are initiated. Which of the following is the most appropriate next step in treatment?
So before you go to the treatment, what is it? Is sepsis, severe sepsis or septic shock? How it is septic shock? What's the definition of septic shock? Refractory.
Well, you haven't tried hydrating.
So what is it now?
Severe.
Or in them, if you could say, okay, what's the appropriate treatment?
IV fluid.
Yes, IV.
How much IV fluid are you going to give us? Dose? And fluid release. Mel spread, keep of crystal, right? Not colloid like albumin or something, yeah, but maybe saline or very good.
One more. Anyone have one?
A 72-year-old man is evaluated in the hospital for urosepsis in the first hour of.
Louder.
A 2-year-old man is evaluated in the hospital for urosepsis. In the first hour of management, blood cultures were drawn, serum lactate measurement was obtained, empiric antibiotics were initiated, and fluid resuscitation was begun. The first 3 hours of hospitalization, he received 3 liters of 0.9% saline. Blood pressure is 80/45. Pulse is 112. Hemoglobin is 11. Which of the following is the most appropriate next step in management?
What? So what's the diagnosis? And the treatment of choice for the septic shock usually is norepinephrine. Or the 94%, I don't know. Okay, just to summarize it before we go towards the end and our resources. Again, identify sepsis. Thanks for Dr. Brink for telling me this. Tachy, white, hot. It serves tachycardia above 90, not 100. Remember that. Tachypnea above 20, white cell count. It could be more than 12 or 10% fast. Temperature more than 38 or less than 30. Order set if you're suspecting or if you're confirmed, doesn't matter. Present on admission, you have to choose that from it. Make a diagnosis. It is SIRS. It's related to pain or something else. It is sepsis, severe sepsis and shock, and then again 1 hour. But these are some of the references I used, but if you want to go beyond that, I have Dr. Brink for you.
Oh, my turn. Not my turn.
It's my-
I was gonna say tacky white hat, but they didn't on the slide.
Sorry.
I learned that as an intern, so just as an FYI, you run into Dr. Monhe, she taught that to me, and I've been relaying it to everybody I've learned ever since. So, yeah, I think that's an easy way to remember. Remember, again, if you suspect it, and then if you rule it out, stop treating it. It's pretty easy. Sepsis is like the easiest, most confusing thing that you're gonna deal with because it's like it either is or it isn't. And just remember it's a pendulum. We're eventually gonna move into sepsis 3, eventually when CMS, stops dragging their feet. I sent over and we're gonna add into the chat so we have it. I just got this email like 10 minutes before we walked up here. From the sepsis coordinator that there's going to be a little bit of a difference in the workflow and the pop-up that you're going to get for septic patients. They're going to go live on the 21st of July. The only thing medicine has changed, so everything changes. And so it'll look slightly different, but it will be kind of the same, and the order set will be the same. So just remember to utilize the order set. We track the patients based off the diagnosis you put in and the order set utilization. And so that's kind of it. So, and just remember, tacky, white, hot. Is it 2 that you got? Make sure to complete the set. Lactic fluids, cultures, antibiotic. That rhymes, so.
Sorry. for tracking the lactic acid, that's not, like, the order set doesn't include that tracking. We have
Yes.
to,
Yes, it.
Oh,
it-
yeah.
Yep.
Okay.
And it auto reflexes.
like the tracking
Yeah,
order.
it auto reflexes, so the nurses should be continuing to.
Okay,
Yeah.
so I should be receiving the results because it's part of the order.
Correct, yeah. And really, I mean, the goal is less than two, right? But there's a lot of other factors and our patients can be a little complicated and those numbers may sit. But if you're seeing a downtrend improvement, you're usually pretty comfortable that you don't need to continuously stick that individual to see it resolve to two. Although that is the true goal is less than two. So speaking of, since Wesley Chapel's on the call, they crush utilization of order set. They crush time zero and early administration of fluids and antibiotics, obtaining blood cultures on time. We're doing a lot better than we used to be. So over the last 3 months, and a lot of this is actually, a lot of this happens in the ER. Probably like 90% of the patients that we get are going to be present on arrival, and the ER is dinged for if they do or don't hit the criteria. So just be mindful of that. But if you notice that you're on the phone with the emergency room provider and you're looking through the chart and you see a picture of sepsis, you can talk to the ER provider about, hey, did you think about this? You know, did you order the sepsis order set?
Yeah.
You know,
And something that you will learn with time that they would order everything, but not the order set. So you do it when you get the patient. Go to the order history, you find out.
and the order set at that point is you just basically putting in the vital signs for the nurse, but it's a placeholder for the chart for basically you can pull data from that.
Tagging.
So if anybody likes sepsis, is interested in this, please let me know. We can get involved in quality improvement projects on sepsis. I can get you involved in the sepsis committee, which we meet once a month and we talk about septic cases. I receive regular emails and I assist in CDI queries on septic patients in the hospital. So it's cool. It's interesting. It saves lives. You know, I don't have enough time to tell all the different stories and situations, but there's a reason that I jumped in and got involved in this and I like it. So if anyone likes it too, let me know.
Yeah, he's my mentor, he's our sepsis guru. So that's who our
I just
compliance.
made a rhyme and all this.
Everybody.
Thank you.
This is not working for me.
I think it works.
Work for you?
It's just